Okay, so welcome to the Practice-Based Learning webinar series. So facilitated by me, Kilima Ibrahim, RCOT Council Member for England and Chair of the England Board, and also a lecturer in Occupational Therapy at the University of East London. So please say hello in the chat, let us know who's joining us today, where you're from, and what role you have in practice-based learning. So we're RCOT, we champion occupational therapy. We're here to help achieve life-changing breakthroughs for our members, for the people they support, and for society as a whole. We promote the value of occupation in improving people's health and well-being. We promote the value of occupational therapy as a means of improving people's health and well-being. Sorry, next slide, I should have said. And the next slide again. Okay, and we have the vision that people everywhere value the life-changing power of occupational therapy. So our profession is growing. We have over 45 education providers delivering over 100 programs, over 7,000 learners, over 1,700 new graduates, increasing diverse cohorts, experiencing a range of practice-based learning opportunities across the 4 pillars of practice. So we need to think differently about our placement opportunities to meet the needs of our learners and our services and the people that we serve. So we've developed a set of, sorry, next slide. Yeah, so we've developed a set of 7 guiding principles of practice-based learning to support the development of quality, sustainable placement opportunities for pre-registration learners, which was launched on the 20th of October 2022 in a collaboration with the CSP. The principles are available to download via the RCOT website, and there should be a link in the chat. And we'll have a range of resources as well that we'll continue to update as we go along. So this webinar series is a supporting resource to enhance placement offers, sustainability, and member knowledge, skills, and confidence. Next slide. Okay, so this webinar is titled Embedding Principles of Practice-Based Learning. Sorry, Innovation in Placement Creation, Embedding Principles of Practice-Based Learning. So the session plan today, so we're going to have 3 presentations, and at the end, after all have presented, we'll have a Q&A session. So if you just, whilst speakers are talking, if you just put your comments and put your questions in the chat. So this webinar is relevant to the principles of practice-based learning, so 1, 4, and 7, also the learning and development standards, and the career development framework across the 4 pillars of practice. So questions and comments. So please put your questions in the chat, share your thoughts, and also on social media, #RCOTPBL, and these are our Twitter handles as well on the slide. Next slide. So, okay, yeah. So the first presenter. So it's titled From Innovative Emergency Response to Sustainability, the Peer-Enhanced E-Placement PEEP Model, presented by Professor Lisa Taylor, Professor in Employability and Learning Innovation at the University of East Anglia. So over to you, Lisa.
Thank you very much. So thank you for that welcome. As already stated, I'm going to be talking around the peer-enhanced e-placement, the PEEP model. Next slide, please. So the peer-enhanced e-placement, PEEP, arose as a result of the face-to-face placement suspensions during COVID. All of us will have experienced this with our students, and we needed an emergency response. A couple of our cohorts of students could either have their placements delayed or merged or addressed in a different way, but we had second-year occupational therapy pre-reg BSc programme that needed to have their placements there and then to help progress their learning. So I created the peer-enhanced e-placement PEEP as an emergency response in order to provide that learning experience for the students. This really is supported around the sort of online delivery in relation to the TOPL review and the NHS long-term plan, which very much supports the digital development of healthcare and the digital literacy of those working within healthcare. From the feedback, we realised that something really positive had really supported that learning journey for the students. The online delivery hadn't necessarily restricted the learning that the students could do. And so we were asked to publish it as an exemplar case study as one of the first online deliveries of a practice-based learning opportunity. And we've published since a journal article as well. Next slide. So the original PEEP, as I've alluded to, was actually delivered entirely online. At that point in time, we didn't have access to our practice educators because of the COVID emergency response that was going on at that time. And so it was delivered not only online, but also in peer group facilitation, hence the peer enhanced e-placement name for the model. What was really crucial is that the placement learning outcomes were at the heart of its design. We didn't want to introduce anything that was new from a learning perspective for the students. We wanted to really reinforce the learning that would have been happening within a face-to-face in situ placement, but just delivering that learning online instead in a different way. We wanted to make sure that all the standards and professional body guidelines are being adhered to, and therefore those learning outcomes, what are classed as anchors really for the design of the PEEP, ensured that learning was really anchored on the professional standards and the related learning outcomes from the RCOT, and also making sure that was progressing the students' learning rather than introducing anything new. So it was something that the students would have been expecting to need to learn relating to their original placement learning outcomes. There was a clear induction process, which was required because obviously online was a little bit different to what they were going to be expecting, and also the way they're going to be working in the peer group. Students needed to be aware of how those clear roles and responsibilities were going to be slightly different to what they otherwise would have been within the in-place in situ placement. There needed to be that cleared shared purpose and the learning outcomes for the placement and how they were going to be learnt and achieved through the online delivery in the way that the PEEP was going to be delivered. The students worked with and took responsibility for a caseload as they would have done within their face-to-face in situ environment, but it was translated into an online delivery in a way that was going to be accessible for the students. They could still progress their learning in those key attributes and skill development. An e-workbook was developed to support the students' learning and also to provide reflective questions to support their learning towards their learning outcomes as well. Next slide, please. So the content of the PEEP have that occupational therapy process at the heart. So each day was divided into separate parts of the occupational therapy process. The student would manage a caseload during that week and work their way through the process. They had background information. They would be involved in initial interviews and problem identification. They were live sessions that would be led by one peer group and listened into by the rest of the cohort that the students found really, really beneficial. Students then set goals for the particular cases that they were managing that week, and then looked at further assessment, treatment planning, implementation, and then reviewed at the end of the week as well. Each week, the students would have virtual multidisciplinary team visits with those multidisciplinary team members who would be relevant for that particular caseload that they're managing that week. So, for example, if we had a paediatric case, it may well be that there would be a teacher as that multidisciplinary team member who would come in and have question and answers with the students as to their role. This really helped with their sort of pre-professional identity and also recognising other members of the multidisciplinary team as well. So the learning was online, face-to-face, peer group learning and individual tasks and reflective sessions as well to help that consolidation and metacognition. Next slide, please. So the way that the PEEP timetable was structured was really, really important to really scaffold that learning journey for the students. So the pacing was really important in the fact that the sessions were timetabled in a way to support that learning journey, but also ensure that it was being done at the right pace for the students. There was synchronous knowledge and skill acquisition, as well as structured supervision and feedback at various touch points throughout the PEEP. There was peer synchronous as well as asynchronous learning, and then asynchronous preparation and reflection as well, ensuring that students were preparing individually for things, but then bringing it to their peer groups, which really fostered that professional reasoning and that interrogation with each other about their decision making, which really helped with their professional reasoning in an in-depth way. And then there was assessment. So we used the usual assessment processes, again, to have that familiarity and continuing of the learning journey for the students. So all of the paperwork and the processes were implemented as much as we possibly could to make sure that process was as familiar as possible for the students and progressed their learning as it would have done in the usual placement setting. Next slide, please. Obviously, those clear roles and responsibilities were really important to make clear at the beginning of the PEEP. In the fact that you have someone who's a PEEP lead, really, who coordinates the PEEP at each locality. The students need to be aware that their roles and responsibilities are slightly different. They're not there just for their own individual learning, but they're there to support their peer group and be involved in peer group learning as well. The long-arm supervisor role is slightly different in the fact that it's not 24/7 support and supervision for the students, because they've got the peer group support and feedback, etc. as well that they're getting. So the long-arm supervisor role is slightly different as well. And an additional role, you've got the case study or scenario, a project lead, whatever it is that your content is going to be for a PEEP, to make sure that there's that support and guidance for students throughout the week that those case studies are being implemented. But again, as an additional role within a PEEP that otherwise wouldn't necessarily be the case within the face-to-face in situ placement, that needed to be clearly identified and engaged with by those involved. Next slide, please. So having had really positive feedback from the initial PEEP, I really wanted to see what was the evidence underpinning that positive learning experience that the students had reported. And came across Professor Gilly Salmon's work, and Gilly and myself have worked since over the last 2.5 years to really develop the PEEP model in something that's much more sustainable beyond this emergency response that the original PEEP was designed for. So Gilly's work extends across decades around online learning. And I realised actually a lot of the work that Gilly had done around online learning and how there's a pedagogy of combining human teaching and technology, and particularly the 5 stages of learning model that is widely recognised across the world. It really seemed to map onto the feedback that the students had actually reported. And what the online learning really did offer was learning in complex and high pressure situations that isn't always possible within the real world. And really recognised as well that practice-based learning goes beyond those hands-on clinical skills. And I'm an Associate Dean for Employability at the University of East Anglia, and for me, thinking about those additional employability attributes and skills that students are developing in addition to their hands-on clinical skills within the placement-based learning setting is really crucial as well. So the 5 stages of learning, there are references at the end of here that you can go and look at this in a bit more detail. But the 5 stages include access and motivation, online socialisation, information exchange, knowledge construction, then develop, where that metacognition really comes to the fore, where students really start to consolidate their learning, reflect upon their learning, and then move their learning forward in their own personal development. And you can see from these titles of each stage of this 5-stage learning of model how the peer enhanced e-placement has really supported the students through these 5 stages of learning multiple times actually through the course of a PEEP, through their peer group learning and also individual learning as well. Next slide, please. As well as there being really rich pedagogical evidence around the online delivery of the PEEP, there is an extensive literature around the peer group pedagogy as well. And the really important thing about group work and peer group work, it's not just about bringing groups of students together. You really do need to encourage that social interaction to support student learning, common and individual goals. So our students had individual learning contracts as well as the more general placement learning outcomes as well to maximise their learning journeys. And it is now really being recognised that it provides a rich learning opportunity and now being realised within clinical education. Next slide, please. Meaning on in-depth learning really helps students prepare for the clinical world of work, including that observation of peers' performance, which we had within the PEEP as well. Really supports enhanced communication, collaboration and critical reflection. Students said it reflected working within multidisciplinary teams, but also that opportunity to consolidate and metacognition as well in relation to challenging each other's understanding and decision making, and then really helping with that sort of what have I learned, how have I learned it, and how is this going to take my learning forward? And what we found time and time again, and it's been reported in the literature around the peer learning, is that equivalent and quality learning gains can help, whilst helping with the placement capacity issues that we're all experiencing at the moment. Next slide, please. So thinking about the PEEP components is the fact that there are three key components really to a PEEP. That professional standards and specific learning outcomes being at the heart of any PEEP. The PEEP pedagogical principles and timetable design, really making sure that it's designed and delivered in a pedagogically strong and robust way. And then making sure that you've got the online placement ecosystem or environment. We use Blackboard, virtual learning environment, again being something that was accessible and familiar for the students as well. Next slide. So what we realised is that we wanted to make sure that other people were able to access the PEEP as well, but also understand the really important pedagogical underpinnings to the way that the PEEP was designed and delivered. So we developed a PEEP acquisition experience, which was a three-staged flip style of learning in the fact that participants on the PEEP acquisition experience would explore their own professional standings and understanding of the key pedagogical components of a PEEP and how that might translate to their local requirements. They would come to a half-day workshop led by myself and Julie, delivered online, where we would go more in depth into the pedagogical underpinnings, look through the timetable structure, deconstruct it, and then help those placement teams reconstruct it in a way that's going to be useful for their own local course needs. And then for quality assurance purposes, a quiz, certificate of completion, then receiving the student e-handbook exemplar as well. Next slide, please. So we've now worked with, is actually almost 70 health and social care placement teams across the UK and beyond, which spans across 20 professions or fields, which if everybody does what they're saying they're going to do, would create over 13,500 potential weeks of placements. And the PEEP model has now been developed, including live links to service users, and has been shown to have that adaptation and adoption for the relevant professional standards across different professions. Next slide. What we've wanted to do all the way along really is not just to rest on our laurels in relation to the PEEP and the PEEP model, but consistently and continually develop it and further underpin the evidence to develop the robustness of the model even further. So we've carried out PEEP research involving an online survey with those people who have attended the PEEP acquisition experience and then implemented their own PEEPs, and really wanted to see what they'd learned from that process and how that might help us in really sort of consolidating our learning with all of the learning we've done around the PEEP model over the last couple of years or so. And we had evaluative interviews just to look at some of their themes in more depth as well. Next slide, please. So from the data analysis, it was all conducted. The research assistant was an independent research assistant, not involved in the PEEP at all. And they carried out reflexive thematic analysis of qualitative data, and quantitative data was collated and analysed descriptively. Next slide, please. So the key findings from the quantitative data is that it impacted on the understanding of online placements and the PEEP design, very much impacted on the value of peer learning and confidence with wider innovation initiatives. We've found that people who've come on the PEEP acquisition experience haven't then only implemented their PEEPs, but they've then gone into and taken confidence with looking at wider innovation beyond the PEEP as well. Most people are planning one PEEP of programme per study and for their second years predominantly, but we've got examples in all year groups, first, second and third years. And again, mostly are planning a 15 working day PEEP, but again, we've got examples up to 6 weeks in nursing, for example, where they've evaluated their PEEP positively, but predominantly 15 working days, sort of 3 weeks or so, has been what most people have implemented. Next slide, please. The qualitative data showed that PEEP has a wide range of benefits. It's a very positive and successful experience for the students. They were able to meet their placement learning outcomes and had added value around that professional reasoning and having a safe space to learn and interrogate their own learning as well, which has come up time and time again. There's a diverse range of case studies that you can actually use within a PEEP. Sometimes those areas that you can't always offer all of your students, you could then target within a PEEP. But their extra support and buy-in from the team, students and practitioners is needed to deliver. Obviously, you want to design it well and then deliver it multiple times, which is a big selling point of the PEEP, in the fact that once you've got it designed once, then you can repeat it time and time again with subsequent cohorts with minimal changes. And the flexible nature of the PEEP was one of its main strengths, reported to be one of its main strengths, in the fact that you can adapt it and adopt it, but still retaining the robust pedagogical underpinnings with its design. And the design of PEEP is a sustainable design, as I said. Once you've had that time to design the initial PEEP, then it is a matter of sort of tinkering with it with subsequent cohorts accordingly. Next slide, please. So the overall recommendations from the research was to work with staff to change mindset. It's a different way of delivering. I think people have changed over the last 2 years, and that mindset is already changing with most people. But I think there's still work to do in relation to the appreciation of what can be achieved with online delivery of practice-based learning. It does encourage and foster collaboration between higher education institutes and placement providers. A recommendation to use that PEEP timetable to underpin that pedagogy and have that framework to help that learning journey. To resource the organisation of the PEEP, and then using that design once and deliver multiple times, sharing resources for that efficiency of PEEP and longer term sustainability. Next slide, please. So you might be thinking, why PEEP? It's sustainable mitigation against further disruption and placement capacity challenges. It really does appreciate those non-hands-on employability and professional development gains for students, but also we're hearing from staff who've been involved who found it really, really positive for their professional development as well. We know it's a robust design, and we've got evidence underpinning the PEEP model with multiple evaluations now have been carried out by different professions with consistently saying positive responses. But it offers an opportunity for local adaptation and adoption for local needs. So yes, you've got that robust underpinning pedagogically with the structure, but the content can be locally adapted and adopted for whatever your local need is. Next slide, please. So thinking about the impact and conclusion, and thinking about how it's gone from an emergency response to a sustainable placement model. It's now been adapted and adopted across multiple professions. There has been generation of placement capacity as a result of this. We've now got example of placement and courses that have been able to increase their student numbers because of the PEEP that they're now being implemented that has increased their placement capacity. We know that placements usually take a lot of time to get up and running when we're sending individual or pairs or small groups of students out onto individual placements, but the PEEP does help with that efficiencies, not only addressing whole cohorts of students in one time, but also efficiencies for students. They haven't got travel time, accommodation worries, or the costs associated with that as well. PEEP is now being included in higher education employability strategy development, not only within health and social care, but also beyond health and social care disciplines as well, because of the robust pedagogical nature that is relevant beyond our area of need. And it's also been included as a case study in a Council of Dean's Health Strategy report. So in conclusion, PEEP started off as an emergency response to COVID. We've worked with multiple placement teams over the last 2.5 years and have developed the model through additional evidence and research and pedagogical underpinning in its robustness. And so it does offer a quality and sustainable evidence-based practice learning model for placement-based learning. Next slide, please. So I've got here all the references for this presentation, and then the next slide, please. And also a number of PEEP resources that Julie and I have developed over the last couple of years to help anybody who might want to look into a bit more of the background of the PEEP in more detail. And then the next slide, thank you. And thank you very much for listening, and look forward to receiving questions towards the end of the session. Thank you.
So thanks very much, Lisa. So please put your questions and comments in the chat, and we'll move on to our second presenter and take questions at the end. So our second presenter is occupational therapy, an occupational therapy placement in public health by Kate Bennett, a principal occupational therapist at Nottinghamshire County Council, and Teresa Rushton, occupational therapy practice placement coordinator at the University of Derby.
Hello, thank you for inviting us to this online conference. We're really pleased to be here. So Teresa and I'm Principal Occupational Therapist at Nottinghamshire County Council, and Teresa, my colleague, works at Derby University. Teresa, do you want to put your camera on? Say hello.
Hi everyone.
Hi. So we're going to do this presentation together. So if we could have the first slide, please, and I'll just invite Teresa in for her slides. So this is about an innovative placement that we created in public health. So adult social care and public health are in one department now in social care. Previously, public health sat in the NHS. So next slide, please. So why did we do this? Well, if you think back to last year, when we had Occupational Therapy Week, we were talking about health inequalities, and that generated so much discussion in my organisation amongst the occupational therapists. And in particular, a reasonably newly qualified occupational therapist came to me and said, I'm really, really interested in working with public health on, in particular, the obesity strategy, healthy weight management and preventing people from becoming overweight. And this got me thinking. So we wanted to raise the voice of people who are plus size. We felt that they were an unheard group who weren't able to access services in social care. And in my organisation in Nottinghamshire, we have quite a lot of people who fit into this, this group. So we needed to influence public health as they held the portfolio for prevention. So I started talking to them about how we might improve what we learned about plus size people, how other professionals in the multidisciplinary team might learn more about how we work with these people and how we could influence change within their health and social care system for them. So from an occupational therapy perspective, the training content focused on changing the individual's behaviour. This is the training that public health were delivering at the time, what they were commissioning. And we felt that that wasn't necessarily the stance that was helping people. So could I have the next slide, please? So alongside that, I was working quite closely with the AHP faculty in Nottinghamshire, and we were talking about how we might increase placement capacity across the system. And we'd already identified potential placements with social prescribing link workers, and we were doing some work on how we could engage the university to work with these link workers who sat in primary care. And whilst I was doing that, it was quite complicated because of the various different employers for primary care. But whilst we were doing that piece of work, I also identified that there was this potential to work with public health and have an occupational therapy placement. So there were some enablers and barriers around that system working to increase these non-traditional placements. As I say, working with primary care, it was about how we got hold of computers, how they accessed case file systems like System 1, those kind of barriers. But I found in terms of barriers and enablers for working with public health, because they were in my organisation, that there were less barriers. So we raced ahead with this piece of work. So could I have the next slide, please? So there is an AHP strategy to inreach into public health for all allied health professionals. And public health do have rotations where doctors come in actually as part of their programme. So they were familiar with having students. As AHPs, we recognise the importance of prevention and its impact on sustainability. And I was able to use this to influence the sort of assistant director of public health to negotiate having the student placement. So could we have the next slide, please? And I think this is for you, Teresa. This slide 4.
It is, yeah. Thank you, Kate. Thanks for handing over. So yeah, where we started from, Kate was instrumental in setting up this placement, or coming up with the idea for this kind of placement within public health, as she's just described. And she contacted me within the university setting to discuss her ideas. You know, that because her organisation, from the council perspective, had a really strong history of kind of actively offering student placements, and a really great commitment to kind of taking our students on placement and offering to support our students in practice. So after meeting with Kate, it was clear that she had, you know, the appropriate knowledge and connections within public health to be able to help us to facilitate a placement within public health. And also, you know, she'd got some great skills in terms of her own motivation and commitment to kind of see this placement through and to kind of be involved in the placement. From our perspective, in terms of the university, we have a history of developing non-traditional placements. You know, we have also a history of looking to match our students within these kind of placements and thinking about the students' capabilities. So particularly for this placement, what we considered was looking at a cohort of students that were pre-masters students, and it was their final placement period that we looked at. And this was on the end of their programme. So the student that we actually looked to place within this placement was due to kind of complete her programme, her occupational therapy programme, at the end of this placement. So we felt that the student had got the capability to be able to take on something that was different, that was innovative, that was new in terms of the public health placement. And together we worked to kind of to trailblaze, to kind of think outside of the box, to think about how this placement might work. And with Kate's connections into public health, we were able to kind of liaise with them. And you know, it was great to see the public health department's willingness and enthusiasm to participate in the placement and to offer to facilitate the placement to the student that was going to be going into this public health placement. The placement took a lot of planning and organising, and it is time consuming, and as Lisa's alluded to, you know, in her previous presentation, you know, setting up individual placements can be time consuming and can you know, be use up a lot, you know, be use a lot of resources up, I guess is what I'm kind of trying to say. But we planned lots of meetings, and so we looked to organise and structure the placement. We met with the public health team. We looked at roles and responsibilities within the placement so that we knew exactly what was going to be happening when within this placement, but we also looked at trying to kind of make sure that the placement obviously was going to be of great quality. We wanted to think about what the outputs of the placement would be in this planning stage. So that's why it was really important to involve public health and to consider what projects the student might be involved in and what tasks we would be expecting the student to complete while they were on the placement. And during this kind of planning and structuring of the placement phase, it was really important for us to consider, particularly from the university's perspective, but also from Kate's perspective as the long arm supervisor, what the overall learning outcomes were going to be for the placement and how the assessment criteria would be able to be successfully achieved within this within the public health placement. Can I have the next slide, please? So in order for a long arm non-traditional placement to be successful, you know, we really needed to have that strong vision and commitment to making it happen. And like I said, that kind of meant that we needed, you know, to be really committed from the very beginning to make sure that we were going to have a successful placement outcome. I think, you know, Kate's influence within her organisation enabled us to be able to articulate and action the vision that we had for this placement. So, you know, she was kind of very able to be able to discuss with public health, you know, what we saw as the vision. Kate, do you want to come in there and talk about that at all?
Can do, yeah. So I guess part of this was the mentor and the relationship with the mentor, who was really open to I guess this experiment, and in fact responded so well and was so involved and so enjoyed supporting our student, and has since progressed in her career and you know, done very well actually off the back of this. So, you know, it was just a win-win all round. So we were very lucky, weren't we?
We were, and I think we kind of saw the benefits for everybody in planning the placement, didn't we? I think, you know, one of the benefits that Kate saw from early on within the placement was that as the principal OT, this was a way to be able to role model to other staff that they could equally be involved in non-traditional and innovative placements in the future. But she was also able to consider that this was a good way for her to be able to be involved in student education, given her role as principal OT within the organisation. So it was time efficient for Kate to be involved in supporting the student from this perspective. It was also really beneficial for the student, you know, from their perspective. This kind of non-traditional placement really enables students to be able to apply the theory into practice. It also kind of helps to strengthen their professional identity. Within this placement particularly, our student was able to work really autonomously, but also to develop networks within the community and within voluntary organisations across the community, as well as developing our own kind of leadership skills, and particularly in kind of project management skills. I'm going to hand you back over to Kate for the next slide, please.
So we located our student in the prevention and wellbeing team, and we deliberately chose projects that we thought would benefit from an occupational therapy influence. So she focused on our green social prescribing rollout, which had been rolled out in the city already for a year, and our ICS needed to roll out into the county. and she also focused on our social eating projects. So some of her work was kind of a desktop audit of services and voluntary organisations that were doing this kind of work and pulling it together in a report. She did 2 separate literature searches on the evidence base, which we will still use. These reports are being implemented into her recommendations are being implemented into practice. It was fantastic work. As I say, a desktop audit of existing services. She was horizon scanning to look for emerging networks and opportunities that link to the projects. So she was meeting people on webinars, engaging in the sort of webinar chat, and then contacting people afterwards and building on those networks, following the links and connections that people gave her. So she was an outstanding student, I have to say. She did some minimal casework that was occupational therapy intervention focused. So she worked with individual people who wanted to engage in community-based resources around managing weight and doing more in the community around sort of green gardening or walking type initiatives. So they'd already been assessed by an occupational therapist and had some interventions done, sort of major adaptations, that kind of thing. But there was this occupational therapy intervention work that needed some time, that was quite complex, that she could really immerse herself in to get a really good result, which she did. If we could have the next slide, please. I think this is back to you, Teresa. Yeah, slide 6.
No, I think I'm doing the last one.
All right, then I'm with you then. So one of the to me to you one of the other things that she did alongside what we called this a leadership placement. Arcot happened to have their leadership program for students running at the same time, and so she attended that program and engaged in the various sessions and found that really, really helpful. Because this was such a new and emerging space that she'd entered into. That gave her a lot of confidence. So well done, guys, from Arcot. She attended, actually, she did a module, a short course at Nottingham University on public health that she was invited to do, and really got a lot out of that. It was all online. She, as I say, attended national webinars and was able to follow up on leads from that. All of her supervision and team meetings were online, which suited our student because she needed to have a virtual placement. So that worked well for everybody. We did a really effective job of doing the casework online. So a colleague occupational therapist who had been working with the person had set up an online meeting round at the lady's house, and dialed our student Lorna into the session so she could have this Microsoft Teams consultation with her. And thereafter, Lorna, the student, was able to do her own online meetings and telephone meetings with the lady. So it was like that facilitated, the relationship was built and handed over to the student in a facilitated way, which worked really well. All of her learning objectives were met. She got an outstanding grade at the end of the placement. I've never had a student that's got outstanding, so I was very, very pleased. And we stretched her, to get that outstanding grade. We did grade those learning objectives to push her out of her comfort zone and to test, whether she could deal with the complexity that we were looking for that grade, and she was able to do that. So there's no performance and capability issues, and the university placement coordinator Teresa and myself as supervisor, we had a plan for any potential disengagement. So I've had failing students before, so I was really keen to work with Teresa on what might happen if. So we had a whole strategy in place with meetings booked in ahead. Should anything have gone wrong during that was it 12 weeks, 13-week placement. and we use those sessions productively actually to check in, but they were also there should we have needed longer time to discuss anything or support the student in a different way. So next slide please, and it's still me, I think. Is that right, or is this back to you?
No, this one is mine.
Oh yeah, to you then,
yeah.
Therese.
Thank you, Kate. So, you know, we really felt that it was important to evaluate the impact of the placement. And, you know, we really felt that from on multiple levels, the placement actually proved hugely beneficial. So from a public health perspective, they identified an interest in having more occupational therapy students within the department, particularly within kind of the homeless team, within the domestic violence team, but also within the falls prevention team. So it was really great for us in terms of thinking about some of that increase in capacity, but also in terms of wider departments understanding what occupational therapy potential and what we can offer. Similarly, I think there was a similar impact in terms of the voluntary services and other community stakeholders. You know, the student was really able to kind of share theory and knowledge and their skills, which really helped those organisations and those stakeholders to better understand the potential for occupational therapy within their organisations. And I think within Kate's team itself, the social care OTs, occupational therapists, they really became interested in the whole idea of new possibilities that they could become involved in with public health, but also in terms of supporting non-traditional placements, and also thinking about the real synergy that occupational therapy has with public health. And of course, you know, ultimately, this has all led to a potential increase in occupational therapy capacity, which is really where Kate started this presentation, that was one of the potential reasons that we facilitated the placement and developed the placement in the first place. I think that's the end of our presentation, and we'll be very happy to take some questions at the end. Thank you.
Okay, so thanks very much, Kate and Teresa. So lots of food for thought there. So the occupational therapy role within public health services. So interesting. So please put your questions and comments in the chat, and we'll take them after the last presentation. So our third presentation, which is the last one, is Student-Led Clinical Learning Environments, CLCLE, Clinical Placement Expansion Project, using a coaching approach to facilitate multidisciplinary student learning and enhance student confidence and skills. So this is Elizabeth Julian, and she's a therapies practice manager.
Thanks so much, Kalima. I'm sorry for the very long title. Next slide, please. So, hello everybody. I'm Liz Julian, and I am an occupational therapist, and I also now have the joy of being a therapies practice placement manager, which is really wonderful. And as part of that role, I've been lucky enough to be involved in our student-led clinical learning environments, which is what we wanted to tell you about today. It would have been a double act. I would have had the lovely Sharon Marshall with me, who is also an occupational therapist, and she's also a clinical educator with us, specifically paid for out of clinical placement expansion program monies to support this project, but she couldn't be with us today, so we'll soldier on without her. So next slide, please. So just to give you an idea, I don't know if you all have heard of student-led clinical learning environments, or you might have heard of something that's very similar called CLIP, so collaborative learning in practice. The idea really originally in our trust at University Hospitals Birmingham came out of our nursing provision, really. So we've got some really wonderful nursing leads who are looking at implementing student-led clinical learning environments, and they wanted to look at it being multidisciplinary and not purely in terms of nursing. So before I was in the practice placement manager post, they had done an awful lot of work. They'd done some, they called them big conversations. So they talked to lots of stakeholders and got lots of thoughts and ideas and reasons why they would look at this different type of model. And so we came in on the back of that, and I really want to give you an idea of where we're at now, that you'll see in the next few slides. So we use a coaching approach, and although in many one-to-one, more traditional style placements, both in occupational therapy and physiotherapy, we may well employ coaching techniques in that. We do try and use a whole team approach. So our healthcare assistants, our therapy support workers, our nursing registrants, as well as OTs, physios, and so on. We implemented lots of coaching training to try and get everybody in that mindset. And we've obviously primed the students that that's what we want to be using as well. And the other thing that's really different about this model is that we have protected learning time every day that's multidisciplinary, and I'll tell you a bit more about that in a moment. Next slide, please. So how is it different? So it's really stepping away from that one-to-one model, which lots more people are doing now. But I think it's probably reasonable to say that there is still a level of people feeling like they need to know a bit more. They feel sometimes that they need a bit more training if they're thinking about taking pairs of students or more. Others feel more comfortable with it. But I think there is a level of resistance at times in some areas to moving away from something that maybe people feel quite comfortable with, the idea of an educator and a student. So we're really stepping away from that with having quite a lot more students to a clinical educator, but also really making sure we're taking that whole team approach so it doesn't just sit on a single person's shoulders. In this case, as I mentioned, we've got Sharon, who's our clinical educator. That role we really wanted to go to an occupational therapist or a physiotherapist, and so it was advertised as open to both. It just happened that Sharon got that role, but it's really something that you see in nursing a lot. You see a lot of clinical educators, and they have practice placement teams in nursing in a way that isn't as widespread, or certainly wasn't, and it's starting to be more so now across OT and therapies in general. So we have a clinical educator role that is different from me as an individual OT taking students. Sometimes this is her whole role. She does not have a separate clinical caseload. As I mentioned, we're taking a coaching approach, and we've got our daily protected learning time, which is really enhanced by the fact that it's mixed disciplines. So you've got nursing students, physiotherapy students, and occupational therapy students in those sessions together, which is really wonderful. And one of the quotes there, which is from a physiotherapist that's already been through one of our student-led placements, is they said the difference is we get to work closely together as a student team. And I think that really gives a feel for the culture of this placement, that they are working as a student team, obviously with the correct supervision and oversight and safety nets. Next slide, please. So really, what's the purpose of the student-led clinical learning environment? Well, in all the long planning, there was a year almost of planning before the first one of our clinical learning environments on an elective surgery ward was opened, and that was actually a year ago now. And so they've been running for a year, and we've opened our second one at Good Hope Hospital on healthcare for older people just on the 19th of September, just gone. And the idea is that we really want students as part of their placement to enhance their confidence and enhance their skills, just as we would on any placement. Within that, though, we really want them to improve their teamwork. We want to really help them understand, as the fourth point there, we really want them to understand the other professional roles that they will be working with in this type of setting when they're qualified, because we want people to work properly together as a multidisciplinary team, and knowing that we've got shared skills and shared expertise, and knowing what each other's specific expertise is, can only be better for our patients. We also really wanted to give a true sense of belonging and actually give a bit of ownership to our students, and help them feel really like their contribution is valuable there. So next slide. The other sort of kinds of aims really and purpose around this type of model was, although it's different from a leadership placement, we also run those, but with at that point of care, helping our students understand that as students and as newly qualified practitioners, they can use and develop leadership skills, and that is a part of it. They take turns to be the lead student that day, and they take on a slightly different role when they're in that position, and they share that and they learn from each other when they're doing that. We wanted really to bridge this so-called theory practice gap, and I think we do have in some settings we have a real well, the gap, I guess, between our sort of ideals about what we might like to do, and some of the realities that we're face to face with, and how yes, we can be innovative, but actually we also have some real life barriers there. So we feel that we're going to have better prepared registrants when they come through if they've had this type of placement. And I think the same goes for other types of placement like leadership. It really gives people a grounding and a viewpoint and a set of skills that maybe we haven't routinely had before. And the last one there, empowering students to really take that responsibility and actively participate in the delivery of care for a particular group of patients. Next slide, please. So the protected learning time that I've mentioned is a multidisciplinary team approach. So whilst we've got a mixed team of students who go to protected learning time, the sessions are actually delivered every day by people from all kinds of different teams that are relevant to the setting. So as I say, this particular student-led clinical learning environment that I'm currently actively working here, I'm here at Good Hope today, they are we are sometimes providing those sessions as therapists. So for example, the session I did yesterday was all around, we sort of workshopped dignity in care, and the groups came up with some really wonderful things, and we really linked that to leadership at the point of care and role modelling, really how all of us from any profession can really make sure we're paying attention, not just paying lip service to being patient-centred, but really thinking about actually what's dignified, where does the respect come in, all of those, lots and lots of things. We've had critical care outreach come and talk to the students. Today we have our nursing educator is doing a session on management of hypoglycemia. Now, clearly that's more of a nursing focus, but it's really excellent for our OTs and physios who are going to be working potentially on these acute wards to have much more of an idea about how that could present and what needs to be done. So the topics are relevant. We have the vulnerability team come down, and for example, we might have somebody from infection and prevention control. We might have people from tissue viability, from the site liaison team, all kinds of people. So it's a really lovely mix. Multidisciplinary team peers share knowledge with each other, and when I say that, I'm talking about the students, because they've potentially had previous placements of their own. They might be first, second or third years, and they really bring that, and that's really lovely. And the students have said to me, you know, we're really benefiting from the richness of each other's experience there, because it is different. You know, it is different when you're a nurse in comparison to an OT or a physio. And those collaborations, the things that we're seeing in the classroom, is we're seeing then coming out on the ward as these students are getting to know each other, working together, learning together. They understand each other better, and it's just so much better for that joint working for our patients. Next slide, please. So I think I saw a question flash up about how often are the placements. So and how many students. So the initial project, which doesn't have a clinical educator, a dedicated person attached, it's the clinical team who are normally on the ward taking the students on the student-led environment. There's lots of nursing students, but in terms of therapies, we just have 2 physiotherapy students each time, and they sort of pretty much run back to back. We're in Birmingham and Solihull, so we have an enormous need certainly for physiotherapy placements as well as OT. So the placements we take from lots of higher education institutions in the area, and we tend to have 2 physiotherapy students on our elective surgery student-led environment the majority of the time across the year. The healthcare for older people environment is, as I've said there, 4 physiotherapy students and 4 occupational therapy students at one time. Currently, because of circumstance, we ended up with just 2 occupational therapy students. So we've currently got 6 therapy students on this placement. Next slide, please. I just wanted to show you, so there is one of our occupational therapy students. She agreed that I could take a quick snap of her in front of the ward doors there. So that's the lovely Megan, and she's on her final placement at Coventry University. And this is a completely new experience for her because she's never been in a hospital setting for any of her previous placements. She's not done this acute physical work, so it's been a really steep learning curve for her, but she's really shown that she's able to meet that challenge. And in fact, that's Megan's writing on the left. We've got a very small room just off the ward where our students and us are using as our base, really, because we just simply couldn't fit that number of people into the existing office. It would have been a health and safety hazard. So there's a little room that we've tried to kind of clean up and tidy up. And as a group, they came up with some therapy room rules, and you can see them there. You know, just good team working and looking after the environment. Next slide, please. The first cohort of physiotherapy students that we had, they were here for 6 weeks and then they finished, and they gave Sharon a very well-deserved card. And I don't know if you can read that writing, but I just wanted to share the comments with you. So we've got, "Thank you for everything you've done for us. You've been the best educator I've ever had, and I'll always remember you. I hope we cross paths in the future." How lovely. And then the other comment there is, "Thank you for all the support. I've enjoyed having more responsibility and feel prepared to enter a band 5 role." And that's really the key, isn't it? That's where we want our students to be at the end of their final placements, which was the case for these 2 guys. Next slide. And in conclusion, the idea really is that our students are working together to provide that holistic, interdisciplinary, patient-centred care. And we see that they are doing that. And we are going to be introducing more allied health professionals into this environment as time goes on. We're going to have some dietetic students, speech and language therapy students, in a slightly different way. Than they won't do their whole placement with us, but they will do part of their placements on our student-led ward. And then in the new year, we'll be welcoming some paramedic students on to one of their non-ambulance placements with us. I really think that having the next generation experience this way of working from the outset will just do a wonderful job in terms of, you know, who's coming on after us. You know, these are going to be our future therapists and workforce. And what I've seen so far, I think we're doing a grand job of really preparing them for that. I would say personally that having a clinical educator in that dedicated post is really essential, in addition to the existing team who are covering any particular ward. That's the case for the nursing students, and they have their own clinical educators. They've got 2, and in therapies our numbers are lower, and so we have a single clinical educator, and they're working very much with the existing team. Our students are supernumerary, and then we are looking at length of stay and other metrics. So in future, I'm hoping to be able to present back some really positive data about that. Similarly to the others in the question session next, I'm happy to answer any queries. Thanks so much.
Cheers. Thank you for that. Really interesting presentations, but we'll just go to the questions first of all. So the first question, I think it's for Lisa. It says, any specific training delivered for LAS? And that's from Hannah. Hanan, sorry.
Yeah, thank you. For everybody who was involved in the PEEP, there are sort of clear introductory meetings, so that each person that's involved, there's clear sort of induction as to what the role and responsibility is for each person. So the long arm supervisors were met with and talked through the paperwork, how the role is different to the usual supervisor role. Students were talked through their role and how that was different to usual, including whistleblowing anybody within the peer group that weren't pulling their weight. And we have had that happen, giving the students the permission to whistleblow on any of their peers who are not contributing to the work and engaging with the peer group learning process. The students actually dealt with that and sort of appreciated the fact that they were given that permission to do so. And then the case study leads as well, in making sure that they're aware of what the learning outcomes are, the level of learning that we're expecting, and all of that sort of crucial robustness really for the learning process for the students. So yeah, preparation is absolutely key.
Okay, so this is a question for Elizabeth. It says, question 2, SLCLE, how did you manage to get all the MDT students out from a different program at the same time and for the same length?
It's a good question. The answer is we haven't been able to do that because clearly we can't do that. So we take whichever students are available at the time, if you like. So the as I said, we're in Birmingham, so the current students we have are from BCU, and in terms of physiotherapy. So when the project first started, we only had physiotherapy students because our occupational therapy students hadn't started yet. They started a week later, so we just brought them in because, you know, the ward is running all of the time. So in terms of the placement itself, or in the student-led environment, that's a constant ongoing. We're going to try, if possible, never to have to stand down the student-led environment now, but it does rely on having our nursing students out, which I think we might end up with a few gaps, for example, over Christmas, just because of the higher educational institutions schedules. So we might have to stand down the environment then, and we won't have any therapists out during that time because our occupational therapy students will have finished. Our second lot of physios have now started, so when the OT's finished, the physios will still be there for a couple of weeks, but then they will finish and we will get a break, and then we'll carry on again in the new year. So we haven't been able to control those other factors. It's purely a case of us adapting, really, so that we can induct people when they need to, and pay attention to their needs and bring them in, even if it's in these layers. Does that make, I hope that makes some sense. Please ask another question if need be.
Okay. Anyone else can put some more questions in the Q&A box. So this is a question for Elizabeth. It says, how involved were the HEIs in developing the student-led approach in terms of student preparation for placement and upskilling staff in coaching approaches?
That's a great question. So our local HEIs were all involved in that sort of long, many months of preparation. So we used to have representatives in our sort of steering group meetings from the universities in terms of nursing and in terms of therapies where needed. We did have to sort of have a break off, and we had a therapy subgroup because there was just too much to look at in the main meetings every time, and we would come back together intermittently. So they were aware of the whole thing. They were on board with the whole thing. And I think the other part of the question that you said was, how involved were they with things like upskilling, looking at the coaching? They weren't. That was done in-house with our sort of education team, both nursing and therapies. And the preparation for the students themselves, where we've got good relationships, you know, we know our HEIs quite well, we know their practice placement teams, so we've obviously included them in the preparation meetings. and ask them to not necessarily handpick their students. We don't particularly want them to do that, but probably to give them a heads up. And then what we've done so far is organise a pre-placement, like Microsoft Teams meeting. So it's been Sharon and myself, our clinical educator and myself, meeting with the students so that a week prior to them starting, so that they can ask those burning questions, so that they can see our faces and feel confident, and they're not coming so much to the unknown. And we also send out a standard letter that gives them a real overview for this. You know, we've developed this student-led environment, this is what it is, these are the kinds of conditions you'll see, you know, all that nice pre-information to give them a feel for what they're coming to.
Okay, so there's another question. It says, are placements also available for master's students? I'm not sure if they mean the SLE, your environment, so I'm assuming it will be undergrads and master's students.
Oh, and masters, yeah. I mean, I'm
Yeah.
sure that if the others want to, but yes, for ours we do. In fact, our BCU students are masters, our physio students just happen to be masters, but we will also take BSc in the future, and our OTs are undergrads. Yeah.
Okay, so I'm just going to I'll ask a question because there aren't any more in the chat. Actually, one more came in. I'm an international master's student and I feel these placements can be helpful. It was a comment, not a question. But yeah, thanks. A question for Lisa. So I just want to, you said in your presentation about there's a live link to service users. So are they discussing their lived experiences with the students, or?
No, what happens is that service users are identified by the practice partner within the practice environment, and then the students lead an initial interview that they otherwise would do. So a peer group will lead the initial interview, or what they've done a kitchen assessment, but the practice educator is beside the service user while that's being done. But it's led by one peer group and then the rest of the cohort listening to what's happening. So they can then really start the students have said it's been great to be able to sort of write their notes without worrying about leading at the same time. It's been great to have that sort of critical lens over what their peers are doing and how they would do it differently. So that's been a really rich learning for the students, and the fact that you can then link into areas that you might not geographically have access to as well. So we've had forensic occupational therapy, eating disorders, occupational therapy, pediatrics, and so it's that sort of live link is when you are genuinely speaking with those service users who've been identified and have agreed to be part of that process. Obviously, part of that induction is very much around information governance and all of the professional standards and everything. That's all part of it's quite a hefty induction process that you do with the students to make sure all of those professional standards and guidelines and behaviours are translated to the online learning environment, including the information governance and confidentiality and all of that sort of thing. So yeah, it's a live link to service users. And that's where that collaboration and partnership working with practice partners is crucial as well. And I think what we found with PEEP as well is that because it's quite timetabled and quite specific, is that some people who perhaps couldn't otherwise be involved with practice placements and the learning because they're working part-time, etc., or working in environments where it'd be difficult to host students, are able to offer and to be part of that either as long-arm supervisors or as the case study leads, because they've got defined periods of time where they're involved that makes that a bit easier for them to access.
Okay, really interesting. So a question from me as well. So to Kate and Teresa, just two questions really. Is there any further plans for placements in public health in the department that you had your first placement? And also, what was the feedback from the actual public health team with your students?
So we had fantastic feedback from the public health team. We're actually, we've got a festival of learning going on in Nottinghamshire next week, and we're presenting on this placement at that for public health. In terms of future placements, yes, we've got the thumbs up if capacity allows to do other student placements. And we've had sort of direct contact from the homelessness team, who are really keen to specifically have an occupational therapist with them on the next placement. And as we said in the slides, the same team that our student was with also does falls prevention, and other sort of preventative initiatives. So they're willing to have another student in that team. I think from my perspective, I'm really keen to continue doing this long arm supervision. As a sort of senior leader, it does give me the opportunity to still be involved with growing our future occupational therapy therapists, should I say. I think that I would rely on Teresa to cherry pick the right student for this kind of leadership placement, because it would it's going to suit certain people more than others. So, for example, a final year master's student worked really well. So watch this space, Calamar. I think we perhaps will do this again next year. I'd be really, really keen. And I know that I've got colleagues who've been quite inspired by this, who would also like to have a go at long arm supervision. So yeah, watch this space. Yeah.
Cheers, thanks for that. And there's another question for Elizabeth. It says, often therapy staff have offices or bases of wards or units. With the student-led placements, were the therapy students on the wards all the time, or were they working shifts like nursing students, or working hours like therapists usually work?
So far, because I can't promise it won't change, so far the therapists, they're doing 8 till 4, so we're doing a classic in the hospital hours. I don't think it needs to stay like that if people would prefer to do something different. There are a few kind of points in the day when we do have to make sure that they're around for, you know, the board meeting or whatever, but we could potentially look at doing shifts, because that would increase our capacity, because the nursing students, not that we would need this number, but we have 28 nursing students across levels of first, second and third year. And the reason is because they will have 2 student nurses in charge per shift. The others are dedicated to the patient care with a ratio of 2 patients to each student, obviously aside from all the registered staff. And because they're doing an early shift and a late shift, and we're running it across 7 days for nursing, that's why we've got that greater number for nurses. We're only doing 5 days for therapies at the moment because we haven't got enough staff to cover the 7 days at the moment, but it would be a nice thing to do, I think, in the future, and potentially look at doing early late shift, or even potentially doing long days, which is what the nurses are now thinking about switching over to. So there's flexibility. I think we're sucking it and we're seeing, but at the moment we're 8 till 4. And in terms of your other comment that yes, usually offices are miles away, aren't they, for, you know, a big walk away from the ward. It's the same here for the existing therapy staff. You know, they come a fair way to get up to where the ward is, so there's a lot of back and forth to find space to write notes and things like that. Our students are based just right outside the ward, because there's a little broom cupboard of an office that we are using. So that's really handy, because the ward is so much more accessible to them. We encourage them to be on the ward really for the majority of the day, but they can come away, which obviously they need to sometimes, including for their protected learning time, which is held in our education centre.
Okay. Just thanks for that. So just to wrap up really, so we've heard of 3 presentations today exploring alternative placement delivery and supervision approaches, such as peer and long arm supervision, and obviously just to enhance the student learning. So we heard about obviously the emergency response to COVID-19, the creation of the PEEP, enhancing digital skills, and obviously non-traditional placements. And obviously this highlighted, I think, thinking creatively really to enable us to respond to the increased demand for placements and to train the future workforce to respond to the changing landscape, and using occupational therapy, the occupational therapy role and the skills where we have, where we can have influence in areas such as like public health, health inequalities and health prevention. And yeah, enhancing a student learning and the student-led clinical, that long word, student-led clinical learning environment, using skills within using the skills obviously within a multidisciplinary team to support student learning on placements. And that's obviously principle 5 in the principles of practice-based learning. So have a look at that. And you'd obviously hear more examples as well through the other series, the other webinars throughout this series. So there's also, next slide, please. So there's oops. Yeah, so there's lots of stuff to think about, obviously, in education, in practice, to increase placement capacity. So to capture reflections and actions and how you might, increase your services, increase placement capacity, what you might do for students to enhance student learning, you may find this 5-minute reflection tool as well useful. And there will be a link in the chat that will take you to the RCOT website where you can download that. And if you're able to, if you could just give us feedback about the webinar today, so you can scan the QR code, and there should be a link in the chat that will give you the form as well if you don't want to scan. And just give us feedback, what we can do better, what we can include, and what was useful for you. And next slide, please. So here's the links. I was talking about the principles of practice-based learning, so that will be in the chat again. So on that link there, you find the principles of practice-based learning, and you just find some other support tools there that might be of interest for you. And next slide. Yeah, so basically, thank you for your time and for your thoughts. And just if you want to continue, you can obviously tweet on social media on hashtag RCOTPBL, and also visit the RCOT website as well. That gives you more resources as well, like I just said previously. And the next slide is some references. So these webinars will be made available online. Don't have a time frame yet, but all of them will be hosted on there with some other resources, and we'll build on that as we go along. So obviously you can watch it back again and all the information. So yeah, but thank you to our speakers, thank you for your time, and thank you to all the listeners, and we look forward to your feedback and seeing you at the next one. Thanks very much.
Thank you. Thanks so much.
You're welcome.
Thank you. Bye.
All right, bye.